Alex Rowe is a medical doctor. He obtained his medical degree from Cornell University and did his MPH at Emory. He was at the Centers for Disease Control in Atlanta, Georgia for 26 years. And for the last couple of years has been working in the field of global health. So he's really a world expert on the issue of quality assessment, quality improvement, particularly focused on low and middle income countries, community health workers. So we'll listen from a world expert on the topic, and I encourage you to make provocative questions on whatever things you might want. Alex, you have the floor. Thank you.
All right, thank you for that kind introduction. I'm going to share my screen. And can you see my slides?
Yes. Yes.
Fantastic. Okay, well, it is such a pleasure to be talking about the effectiveness of training strategies to improve health worker practices in low and middle income countries, a systematic review. So let's start with the big picture. What is quality? Why does it matter? So quality has many perspectives, including structural quality, such as the availability of medicines and equipment, quality assurance, program quality, and healthcare quality. So what I'll be talking about today really focuses on healthcare quality in terms of health worker practices. So they're direct practices such as correct diagnosis and treatment. So why does this matter? High quality care is needed for country programs to have impact. And in fact, improvements in health worker practices is correlated with improved health outcomes, which is really what we want to achieve. Secondly, poor quality is a big problem in low and middle income countries. Only half of patients typically receive the medicines, the treatments that they need, and that's among those patients that are seeking care. Problems with lack of access is another huge problem. We won't be talking about that today. Also, poor quality has a very high burden. So an estimated 5 to 8 million deaths annually and $1.5 trillion in lost productivity, which perpetuates poverty and diseases of poverty. Third, there are feasible ways to improve quality, and in a sense, that's what we're here to talk about. And then finally, there are some important efficiency issues. So poor quality is fundamentally wasteful in terms of medicines, diagnostics, out-of-pocket expenses, and of course, people's time. Okay, so moving on to training. So this is definitely the most common approach to improving quality. So let's talk a little bit about how much we spend on this. So with regards to the President's Malaria Initiative, or PMI, so I was at CDC for a long time and spent a lot of time working with PMI. So I looked at all 72 country-specific PMI annual budgets between 2017 and 2019. Every single one of them included funding for training health workers. And then at Global Fund, so this is the Global Fund to fight AIDS, tuberculosis, and malaria. When you look at their last completed 3-year funding cycle from 2018 to 2020, they budgeted nearly $500 million on training. And this level of spending is likely to be even more for the current 3-year funding cycle of 2021 to 2023. But in addition to dollars, there are other costs for training. And I'm thinking about opportunity costs. So training takes health workers away from their clinical duties. And I'll give you a pretty extreme example of this. This is really true based on a Ministry of Health official's presentation. In the Philippines in 2018 to 2019, health workers spent between 25 and 42% of their total workdays on training, and that includes travel. Keep in mind that Philippines has a lot of islands, so traveling any place takes time, but that's a very impressive opportunity cost for training. There are some important questions about the effectiveness of training. So let's begin with some observational studies. So 8 national health facility surveys in Africa found that training had no meaningful effect on quality. And on the right, you can see a map where these health facility surveys were conducted. A little bit more recently, there's a large systematic review of the effectiveness of strategies to improve health worker performance in LMICs, and that examine this question. And this is it's called the Healthcare Provider Performance Review, or HCPPR. And this is a project that I've been leading for quite a few years. And the effects of training on health worker practices varied substantially. Everything from like negative values all the way to large positive improvements, with a median improvement of 10 percentage points. And this is based on an analysis of 78 study comparisons from 31 countries, so really quite large. And on the lower right of this slide, you can see the Lancet Global Health publication from 2018, where these results can be found. In addition, with this article, my team performed a modeling exercise which examined the marginal effect of training. So let's say you have an intervention package to improve health worker performance. For example, it could be supervision or financial incentives or combinations of things. On average, when you added training to some package of interventions, on average, training led to an improvement of the effectiveness of that package by a mean of 6 percentage points. So that's the marginal effect of training. Now, these analyses were all very interesting, but there is an important limitation, which is shown on this slide on the left. So multiple training approaches were all combined into a single, fairly heterogeneous group. So it combined group in-service training plus self-study. It looked at training with different durations and that used training that used different educational methods. And I think these limitations motivated my team to kind of look at the question of training effectiveness in greater depth. And that brings us to the objectives of the main analysis that I'll be presenting. And this was published in BMJ Global Health. And you can see the publication on the right side of this slide. So the objectives were twofold: to analyze the HCPPR systematic review data to do two things. First, to characterize the effectiveness of different training strategies. So the idea is to really drill down into the database and look at different strategies more closely. And second, to identify the attributes associated with group in-service training effectiveness. Now, group in-service training is by far the most commonly used and commonly studied approach, training approach that we have. And the thinking is that some in-service training tends to be more effective than others. So let's see if we can identify what attributes are of the more effective training programs. And the idea is that if you could identify these attributes, it would suggest ways to increase training effectiveness in the future. So those are our two objectives. Okay, now let's talk about methods. The evidence source is the Healthcare Provider Performance Review. And this is a screenshot of the review's website, and the site is at the top of the page, so www.hcpperformancereview.org. Now, this is a systematic review of the effect of any intervention to improve health worker performance in a lower middle income country. And I'd like to draw your attention to the left-hand side of this screen. So there are a couple of different tabs on the web, in the website, on the web page, and you can download databases. If you wanted to perform your own analyses, you can find additional publications. So any of you that are really interested in this topic and that might be interested in kind of doing your own research, perhaps this website and the review would be a helpful resource. Okay, so in this review, health workers were defined quite broadly as facility or community-based health workers, as well as pharmacists, shopkeepers who sell drugs, and health workers in the private sector. It generally uses Cochrane review methods. So for example, eligible study designs include controlled trials with or without randomization and interrupted time series. For the literature search, we searched 52 electronic databases for published studies and 58 document inventories for unpublished studies from the 1960s all the way up to 2016. And we screened over 216,000 citations. The overall review included over 700 studies on more than 100 different strategies. And just to give you a sense of the scope of the review, that Lancet Global Health paper that I talked about from 2018 a few minutes ago, that one paper presents the effectiveness of 118 different strategies. So that's something to think about. The review included many different outcomes. Today, as I mentioned earlier, I'm going to really focus on health worker practices, on things such as patient assessment, diagnosis, treatment, counseling, and so forth. Now, the outcomes come in kind of two flavors, two metrics. The first is outcomes expressed as a percentage, for example, the percent of patients treated correctly. And then the second is continuous unbounded outcomes, for example, the number of medicines prescribed. Now, these two types of outcomes have different mathematical properties, so you can't really combine them very easily. So I'll be presenting these results separately. Effect sizes were calculated in terms of an absolute percentage point change. So for example, for outcomes expressed as a percentage, which is the largest group of outcomes, the effect size was simply the follow-up value minus the baseline value in the intervention group, minus follow-up minus baseline among controls. And this is also known as an adjusted risk difference. So here's just a quick example. So this is a hypothetical study with a little graph on the left-hand side. You can see time on the x-axis. There's a baseline value and a follow-up value. And then the y-axis is the performance indicator, in this case, percent of patients treated correctly. So in green on the top, the performance level increased in this hypothetical study from 25% of patients treated correctly at baseline to 50% at follow-up. So that's a change of 25 percentage points. In the control group, in blue, we see there was also an improvement from 20% performance up to 30%, or an improvement of 10 percentage points. So the effect size is the difference between these two, or 15 percentage points. Did someone say something?
No, carry on.
Oh, very good. Okay, so a word on the interpretation. So if you had, for example, a baseline performance of 40%, so 40% of patients get correctly treated, with this hypothetical intervention, you could add that improvement of 15 percentage points. So at follow-up, the performance level would be 55%. Another way of thinking about this is that for every 100 patients seen, 15 additional patients were treated correctly because of the intervention. Okay, so what were the training kind of interventions? What were the categories? And these are all mutually exclusive. So the first is group in-service training. This is the most common, and it's an on-the-job training. Typically, imagine kind of a group of health workers in a classroom or a clinical setting receiving their training, but again, by far the most common. Next are educational outreach visits or academic detailing. And here you have face-to-face visits of individual health workers at their workplace by someone who the health worker might regard as an expert, and the idea is to promote best practices. So, for example, an expert physician or some kind of specialist. Next is self-study. And so here you have structured sessions in which the health workers are really studying by themselves without any kind of attendance in a class or anything like that. And the health workers might occasionally interact with a facilitator or with peers to discuss the training content, but largely self-study. And then finally, peer-to-peer training. And this is when you have one health worker basically teaching another. So for example, you could have a health facility in charge attending a training in person and then returning to his or her clinic and sharing that information with the other health workers. So that's peer-to-peer. A word on the comparison types, because this is evidence-based. This has a lot of different kinds of studies. So the first type is training alone versus a control group that doesn't receive the training. So kind of business as usual. The second is when you have a head-to-head comparison of one training type versus another. For example, group in-service training versus educational outreach. The third is training plus some other intervention component, for example, supervision, versus that other component. So for example, training plus supervision versus that same type of supervision. And this kind of comparison tells you the marginal effect of training, given that there are other intervention components in the mix. And then finally, head-to-head comparison of two different training types, but in the context of having other kinds of other components in the mix. With regards to the second objective of identifying attributes associated with training effectiveness, we looked at a lot of different attributes. I won't read all of these, but things like training duration, the methodology, whether or not all the training was done on site, and so forth.
He's probably just carrying on talking, right? Yeah.
Oh, can you still hear me?
Oh no. You know, let me get the lights.
Can you still hear me? Can you still hear me?
Yes.
Ah, very good.
Yes.
I'll continue. With regards to the modeling for this second objective, we performed random effects linear regression modeling of 3 hierarchical databases. So you'll see that each of the databases kind of builds on the one before it. So the first was training by itself. And we had 55 studies in that. Next is training by itself or with supervision. And these models were all adjusted for the presence of supervision. So we had 73 studies in this second database. And then the biggest was training with or without any other intervention component, again, adjusted for those other components. And we had over 150 studies. So the reason why we had these 3 databases is that, in a sense, the first one with 55 studies is the purest because it's just the training intervention. But it was the smallest database. And then as we allowed the inclusion of other elements, our sample size increased, so that was a good thing. But then the complexity of the analysis also increased because now we had other interventions in the mix. And then the models were fitted with and without 2 known confounders, baseline performance level and time since training. And that's because based on previous analyses, we knew that these 2 attributes were associated with intervention effectiveness. So we wanted to control for those. Okay, so let's start with just an overview of the studies. The analysis included 199 studies with at least 1 health worker practice outcome. And that represented a very wide range of contexts in 51 countries. 58% of studies had randomized designs, so that's good. But 60% of studies had a high risk of bias, and that's important to keep in mind when interpreting the results. There was no evidence of publication bias. We found that studies were often short. The median follow-up time was just 4 months. And studies were often small. The studies had a median of 16 health facilities and 98 health workers per study. And then finally, the training aimed to improve quality for a pretty wide variety of health conditions. So pneumonia, diarrhea, sexually transmitted diseases, non-communicable diseases, on and on. Okay, so let's look at the, let's tackle objective 1, the effect of different training strategies. And I'm really going to spend most of my time talking about the effects on professional health workers. And by that, I mean facility-based physicians, nurses, midwives, things like that. In a few minutes, I'll talk about lay health workers or community health workers, because they're clearly also quite important. So group in-service training versus control. So the median improvement was 7 percentage points for percent outcomes. And there were 60 studies here, so it was quite a large group. And a median improvement of 17 percentage points for those continuous outcomes. And if you look at the subset of studies that had high quality design, so a low or moderate risk of bias, the median improvement was just 5 percentage points, so quite a bit lower. So if you look at the best quality studies, the effectiveness, drops down even a little bit. So let's talk about these results for just a moment. So this 7 percentage point improvement, so it's based on 60 studies, that's quite a few studies. So training improves the quality from a mean baseline value of 40%. So keep that in mind. Before the training, only 40%, on average, only 40% of patients were getting whatever they needed in terms of diagnosis, correct diagnosis, treatment, and so forth. And then after the training, the median improvement was 7 percentage points. So that gets you to a follow-up value of 47%. Okay, so if you think about the baseline value, performance level of 40%, well, another way of thinking about that is that the quality gap is sort of the complement of that. So it's like a 60% quality gap at baseline, all right? And then you do the training, and then the gap is reduced by that 7 percentage points. So the gap is still pretty large at follow-up, isn't it? 53%. So, training typically reduced that quality gap by about 12%. So in other words, if training were a vaccine, the efficacy would be something like 12%. If you look at the marginal effects of training, so as a reminder, that's training plus some other intervention versus that other intervention. The marginal effects were a median of 4 percentage points for the percent outcomes and slightly negative 7 percentage points for continuous outcomes. Now at this point, let me say that the number of studies is getting quite small. So for example, that last value of -7 is based on just 4 studies. So you have to be really careful about, you don't want to overinterpret that when the evidence gets that thin. The key message here is that group in-service training tends to have just sort of a small to modest effect on health worker practices. Educational outreach visits or academic detailing. When we examine this versus control, the median improvement was 10 percentage points, and these were all from percent outcomes. And the marginal effects was a median of 21 percentage points. So let's look at some head-to-head comparisons. When you looked at educational outreach visits versus group in-service training, it was just one study, unfortunately. And that median effect was just 1 percentage point, but again, just one study. And in fact, that was one high risk of bias study, so the quality of the study wasn't even very good. When we do a head-to-head comparison in the presence of other intervention components, educational outreach visits had a higher marginal effect by 6 percentage points. And that was based on 2 studies, not very much, but at least those were a high quality study. So that's a little bit better. And the key message here is that educational outreach visits might be somewhat more effective than group in-service training. For self-study, with self-study compared to in-service training, the improvement was 9 percentage points. And for group in-service training, in combination, so self-study plus some other intervention compared to group in-service training, self-study, the difference was 2 percentage points, with group in-service training being better. So the key message here is that group in-service training might be a little bit more effective than self-study. And if you look at peer-to-peer training, it's a similar kind of message, although again, the number of studies is just very, very small. Okay, moving on to lay health workers or community health workers. Unfortunately, there's really not that much to say. We had just 5 eligible studies, all had a high risk of bias. There was essentially no effect of group in-service training, no effect of educational outreach visits. For the second objective, remember, we want to identify attributes associated with group in-service training effectiveness. I'll begin with associations that were statistically significant at the 0.05 level. So first, the mean effect of training when some or all of the training was done where the health workers routinely worked, so on-site training. that tended to be more effective than having all the training being offsite by 6 to 10 percentage points. And so by offsite training, for example, it might be done in a hotel or something like that. The second main finding was that training that had clinical practice as an educational method tended to be more effective than when that wasn't used by a mean of 7 percentage points. Looking at the two confounders that we examined, there were sort of two interesting findings. The first is that the effective training tended to decline over time by an average of 1 percentage point per month. And let me add here that after this study was published, my team collaborated on a second analysis that really just focused on the effect of interventions over time. And that also found a significant decline in training effect, but by a smaller magnitude. But both analyses were in agreement that there was a decline over time. And then the training effect was greater with a lower baseline performance level. So for every 10 percentage point decrease in baseline, the training effect was 1 to 2 percentage points higher. So that kind of makes sense. If your baseline performance level is really low, you have a lot of room to improve. So effect sizes tended to be a little bit larger. Or if you sort of flip that around, if your baseline performance level is very high, there's not that much room to improve. So effect sizes tend to be a bit smaller. We also found a few attributes that were tested by just one study each, but they had relatively large effect sizes. So I've got a caution here on the left side of the slide. I mean, if it's only one study, you really can't take it too seriously, but I thought it was at least interesting to share. So the first was that training that was tailored to health workers' stage of readiness to change tended to be more effective by 23 percentage points. Pre-service training with group feedback, 19 percentage points. And then training that used a protocol was more effective by 8 percentage points than when health workers just sort of used their clinical judgment to come up with a diagnosis. But again, just one study each, so we need to be kind of cautious. And then there were quite a few attributes with little or no effect on training effectiveness. The first is training duration. And some of you might be thinking, hold on, how could training duration not be associated with training effectiveness? Like, aren't longer trainings better than shorter trainings? All I can say is my team looked at this so many different ways, and we just could not find a signal in the data. We're not quite sure why, but this is what we found. Also, training with computers, educational methods that were interactive, and also the use of written materials, training over multiple sessions, the number of different educational methods that were used, training via live video interactive sessions, use of trainers that had some kind of pedagogical training, and then topic complexity. Now, you might also be wondering for this, the third one from the bottom, training versus live video interactive sessions. So I want to emphasize that the literature search was completed in 2016. So that's before the kind of COVID era, video sessions like the one we're having right now. So my team's review didn't include evaluations of this simply because of when the literature search was done. So that's a limitation of the review. And then there were also 3 attributes where the associations were kind of unclear because of conflicting results. So for example, head-to-head studies showed one thing, but the modeling showed something, something in a different direction. So training group size, use of trainers with content expertise, and non-interactive lectures. Okay, a word on the cost of group in-service training. Again, this is for professional health workers. So training is related, the overall training course cost is related to the number of health workers that are trained and the duration. And because of that, we standardized costs to be the cost per health worker per day of training. Okay, so among studies of group in-service training, data on cost or any kind of economic evaluation were only available for about 1/3 of studies. So this tells you there is a big gap in the literature. Really, I think all studies of intervention effectiveness should have some kind of evaluation of cost or an economic evaluation. So it's quite telling that we only had data on this from 1/3 of studies. Among the 15 studies where we were able to calculate the cost per health worker per day of training, we found the median cost was $26 per health worker per day. We found that the costs were not related to the study year and whether or not the training was done on-site versus off-site. And the costs tended to be a little bit higher in low-income countries compared to middle-income countries. But again, the numbers are quite small. A word on limitations. There are quite a few. First was the limitations of the included studies themselves. So non-standardized methods, the differences in context. There was often a high risk of bias, short follow-up time, and missing values for some attributes. Secondly, and I think this is quite important, the generalizability of these study results to real-world programs is unclear, right? Because these studies were done in somewhat controlled settings. So the effect of real-world trainings may be even lower than what I've been presenting to you. Third is that most training strategies were tested by few studies. Fourth, not all potentially relevant training attributes were even abstracted by the systematic review. Fifth, the modeling results reflect hypothesis screening rather than true hypothesis testing. So keep that in mind. And then finally, the HCPPR admittedly is somewhat out of date. For example, I mentioned this a minute ago, there have been no evaluations that were included of COVID-era training by video calls. And that's clearly something, a gap that should be filled given the proliferation of video training. Okay, so that was a whole lot. What does it mean practically? Okay, what does it mean for programs, for donors, technical partners, researchers? So first, in-service training alone tends to have small to moderate effects. And this is based on a pretty big evidence base, right? 199 studies. And so really, I think we shouldn't be relying on it so much. And I'm thinking back to that Global Fund amount of spending on this, nearly $500 million over 3 years. And better options exist. And I think that programs should really seriously consider repurposing some of their existing training budgets, which sometimes are really quite large, to support training. So I'm not saying training should go away, but to support training in combination with other interventions that have been shown to be effective. For example, group problem solving, certain multifaceted strategies, and then also to use some of those training budgets on monitoring quality, which I think is really quite fundamental to quality improvement efforts. Second big point is that educational outreach visits might be somewhat more effective than group in-service training, which in and of itself might be a little bit more effective than peer-to-peer training or self-study. So that was the first objective that we looked at. Third, some training approaches really do seem more effective than others. For example, on-site training and training that uses clinical practice, and programs should consider using these when designing training interventions. Fourth, for community health workers, in-service training alone really had no effect. But again, very few studies, and the studies were not very good quality. Fifth, the quality of the evidence on training is relatively weak, and some important knowledge gaps remain. Now, the HCPPR generated an evidence-based research agenda, and I think that could serve as a roadmap for future studies. For example, we need more replication studies. We should be using more rigorous study designs. We should use standardized methods, and certainly more studies of community health workers. And then finally, although more research is needed, I think decision makers really should be considering these results when thinking about investments, when thinking about their interventions. in order to make training in LMICs more effective and ultimately to strengthen health programs and improve the lives of individuals and populations. Thank you so much.
Fantastic. Thank you so much, Alex. Hope you can hear me, and even better if we could have the camera point to myself and Jennifer while we are asking questions. So the format is that a student of the master's and myself, Jaime, the executive director of our Institute of Global Health here at UCSF, will be posing some questions and then we'll open to the audience. So that is the format. Jennifer, would you kindly join me? Okay, so we'll use the room microphones and hopefully you can hear us, Alex. Is that the case?
Yes. Yep, I can hear you. Thank you.
So I have a first question for you. I was intrigued and very interested on the notion of cost. One of your slides mentions that there is an opportunity cost, and I totally agree with training. However, I was surprised to learn from one of your slides that training per day has a median of about $26, $27. But then you mentioned that in low-income countries, the median cost is much higher, while in middle-income countries, it's about half. Why is that? Could you please explain?
Yeah, so thanks for the question. The systematic review database didn't collect any specific details on what might be influencing costs. So my response is really based on a lot more on my personal experience than the database itself. So I wanted to start with that. So in my experience, in many of the low-income countries where I've worked, they're kind of categorized often as challenging operating environments. So these are places where there are often large problems with physical insecurity, kind of getting places, moving around is often expensive. And so the infrastructure is such that it just is a lot more difficult operationally to conduct the trainings. And also, I think when you have trainings that are primarily conducted by outside groups, because I think for these studies, sometimes, the studies were done in collaboration with ministries of health, but not always. And I guess maybe the cost of having outsiders come in the low resource settings just was more expensive than places in middle-income countries where it was easier to get around and things like that. I'm seeing a message saying we can't see or hear you.
No, that's a while.
No, that's all. Okay, very good. So that's a little bit of speculation, but certainly when I think about my own experience in doing trainings in rural areas of low-income countries, the costs really expand pretty quickly.
Thank you. Let me pass the floor to Jennifer Chimbupa, who's a student at the master's. Jennifer?
Hi, thank you, Dr. Rowe, for your presentation. I had a question about how you and your team define quality of care. Was it just like health outcomes or healthcare worker behaviors, performance? And also another question about how you guys took into account like things that affect baseline healthcare worker performance and how that may affect the effectiveness of the trainings and how you guys accounting for that in the calculations.
Yeah, thank you. Great questions. So with regard to the definition of quality, The simple answer is whatever indicators were used in the studies. And when you look at the entire systematic review, all 700 plus studies, these studies had well over 1,000 different outcomes. It is the Wild West when it comes to methodology of these kinds of studies. As I mentioned in the presentation, so what we did was, we couldn't lump all of these different outcomes into a, we couldn't lump them all together. We felt, for example, it wouldn't make sense to combine analyses of health worker practices with health outcomes because, if you talk about like changes in mortality rate, those changes would be, quite small on an absolute scale, and you'd have to look at it kind of as a relative measure. And also, the causal pathway between an intervention and a health outcome is relatively long, but the causal chain between a quality improvement intervention and health worker practices is actually relatively short. So in this analysis, it was really just looking at health worker practices. So, like the health worker is examining the patient or is making a diagnosis or is prescribing, medicines or other treatments or counseling. So those were that was the subset of outcomes that were the definitions of quality that were used for this analysis. There are other analyses that look at other kinds of outcomes, and maybe some other time we can talk about that. With regards to baseline, if I understood the question correctly, you were asking about kind of, I guess, what the influences were on health worker performance at baseline. And, we didn't really know what those were in most studies. Every so often, some studies would do some analyses and they would talk a little bit about, the factors that were associated with baseline performance level. There were some studies that did that, but not that many. And so our thinking, perhaps a little bit simplistically, was whatever that baseline performance level was sort of the end result of whatever the factors were, the facilitators as well as the, barriers to providing good quality care. That baseline level, we think actually is sort of a, in a sense, a good summary of performance for that particular outcome. But it's a very interesting question that you're asking, because if you want to improve quality of health services, a perfectly good question to ask is, well, what seem to be the problems at baseline?
You also talked a little bit about like the costs, the opportunity costs. Did you and your team see any other adverse effects of these training programs or any? Yeah, that makes any sense.
Yeah, no, it's a great question. So when doing implementation research, to me, the kind of gold standard implementation research does look at the potentially harmful effects of an intervention. Often that's not done. And if there were harmful effects of an intervention, it's not even clear to me that an investigative group would want to write those up in their in their publications. So we were not able to look at that in any kind of systematic way. And so really that example from the Philippines, for example, it came out of a discussion. There was a kind of a seminar, and someone from the Philippines was talking about the problems they were having with training. And really, I think it was an entree, if I'm remembering correctly, it was an entree to a discussion about virtual training. And this was during the COVID era, so that kind of makes sense. And I think the Ministry of Health official was trying to show how bad the opportunity costs were in the Philippines. Probably an extreme example, but it really struck me. So I hastily wrote that down and made sure that it was a solid citation, something I could cite and share.
Fantastic. We only have about 6 minutes left, and I would like to give the opportunity to the audience here also to pose questions.
Alex, great presentation. 2 related questions. From your analysis or expertise, can you give us any insights into the effectiveness with respect to who gives the training, whether it's the Ministry of Health versus local academic partner versus international academic partner? and also modality of training, and thinking specifically about educational technologies that have become more commonplace during COVID. Can you give us any insights into the effectiveness of training over an LMS or Zoom, as compared to in-person training? Over to you. Thanks.
Great, thank you. Fantastic questions. So with regards to who gave the training, the systematic review did not have a data element specifically for that. And so I can't answer it. What we did do, though, is that we looked at attributes of the trainers, not in terms of kind of the organizational origin of the people, but just their actual attributes. So for example, the two specific ones were whether or not they had pedagogical expertise. So, did they have some background in being a trainer? For example, there are many training programs where the trainers receive a training of trainers course. WHO puts those out. I'm sure there are other sources as well. And then another was whether or not they had content expertise. So for example, if the training was done, if there was a training about the case management of pneumonia, was the training given by just sort of any old doc, or was it a pulmonologist who had special content expertise, or maybe an infectious disease specialist? And for those two attributes, we did not find an association with the effect size of the training program. For your second question about the modality, so the one signal that we did find was that when the educational method, or well, I guess two things, was included clinical practice, trainings tended to be more effective. And when, with regards to locale, when the training was done on site, in health facilities, in the health workers, clinics, the effectiveness was greater. But with regards to the use of technology, which you kind of mentioned as you were posing the question, there were only a very small, just a very, very small number of studies that used technology. And that kind of technology was definitely not the kind of more sophisticated video calls that are being used, during the COVID era. And so unfortunately, the literature search was ended in 2016 before, this kind of modality now is very mainstream, of course. I think that it's very, very important to do rigorous evaluations of these methods. And really, there are a couple of reasons. One is that they're being used all the time. And so we really do need to do that. And second is that when you look at the kinds of evaluations that have been done so far, it tends to be, the outcomes tend to be the kind of level of satisfaction of the attendees. And I feel like that is probably not going to be a very robust kind of outcome. I think if you have some group of health workers in Somalia and they're getting some training via a video call on the case management of COVID, they're probably going to be excited to get any information in any way possible. And similarly, if you but I don't think their impressions of it, it's probably not the most robust kind of outcome. And then there have been other evaluations where they use knowledge as an outcome. For example, there could be a baseline test that they give the health workers before and then after the video session, or maybe a series of sessions. And I kind of get that, right? I mean, the mechanism of action of a training program could certainly be through improved knowledge and skills. So I certainly understand that. However, and this is actually an analysis that hasn't yet been published, but my team has finished the analysis. And what we did was we looked at changes for studies that included both changes in health worker knowledge and, in the same study, changes in health worker practices. We found that there was actually almost no correlation between the two. So, changes in health worker knowledge and skills, I mean, they're easier to, it's definitely something. I don't need to completely devalue it, but it's relatively easy to measure. but those improvements tend not to be correlated with health worker practices. And health worker practices are actually really, I think, good measures of impact because they have been shown to be correlated with improvements in health outcomes. And that's another piece that my team has worked on. Sorry, that was a little bit long-worded and a little bit methodological, but I did want to make that point. And so I hope maybe someone in the audience will prioritize that as a study project, because I think we really do need high quality evaluations of these kinds of training methods. Over.
Thank you so much, Alex, for a really fascinating presentation on a very important topic in global health. Let me ask the audience to join for an applause for that.